Grant Larson here. We're here with ArcticDX and we're talking about genetic testing for AMD.
Greg Hines here, President and CEO of Arctic Diagnostics.
And I'm Brent Sankey. I am the Chairman and the Chief Medical Officer of Arctic Diagnostics.
Tell us a little bit about diagnostic testing for AMD.
Well, diagnostic testing for AMD is actually a very new thing. Eye care professionals that actually manage macular degeneration normally do most of the diagnostic testing in their own offices with their own equipment, a lot of imaging machines, etc. So this is the concept of doing a DNA test related to macular degeneration is a fairly new evolution in the management of the disease. Something that eye care professionals seem to embrace, the fact that they can be accepting maybe a cutting edge technology to bring themselves into a point where they really understand a particular patient, the personalized needs of that patient, and how best to manage that disease.
What's the importance? We hear a lot in the press nowadays about AMD. Why is that?
Well, AMD is a huge public health problem. It's estimated that about 10% of people or more throughout the course of their lives are going to suffer visual loss related to this disease. And what's interesting about the disease is that there's a very long period of time where you have the condition that isn't associated with blindness, but people do progress onto blindness over the course of several years. And what happens during those years from when the disease is first identified to when people are going to suffer visual loss can make all the difference in terms of whether they themselves are going to get visual loss or whether in fact they might get it but at a later date. So it provides a great opportunity for doing something that's going to have huge societal and actually personal benefit. And genetic testing, which is relatively new for the disease, provides just such the tool that's going to be able to make that kind of difference.
Just to add to that, just for a moment, I picked up a journal this morning before we met in Ophthalmology Times, and they had a great article on macular degeneration and the evolution of this disease over the last 20 years. And they pointed to the fact that the world population has grown by about 30% in the last 20 years, but blindness due to macular disease has grown by 36%, and vision loss due to macular degeneration has grown by 81%. So with an aging population around the world, this is a disease that's becoming much more prevalent and is growing much faster than the population otherwise would lead you to think.
It's a huge public health problem because as we're all getting older and the prevalence and incidence of the disease are getting greater and the treatment is so expensive, unless there's a radically new way of reducing the burden of the disease, it's going to create a huge strain on all healthcare systems in Western countries.
Your company provides a couple of services and a number of products. Can you tell us about macular risk and tell us about VitaRisk specifically?
Sure. Well, when Caucasians in general tend to get into their 50s and 60s, about half of us develop these little yellow spots in the back of our eye. They're called drusen. Your optometrist or eye care professional can see them routinely when he or she does an eye examination. Those are the early signs of macular degeneration. About 20% of the people that get those little spots as they live through their 70s will actually progress to lose vision in at least one eye. So what does the eye care professional need to know when he sees those little yellow spots? He needs to know whether or not you're in the 20% that's going to go blind or the 80% that's okay. So what macular risk is a DNA test from a little cheek swab in the doctor's office that tells him with 90% accuracy whether or not you're going to lose your vision in the next 2, 5, or 10 years. From that, the doctor can put a disease management program in place to help prevent you from losing your vision. The second part of that test is VitaRisk. And the interesting thing about VitaRisk is that for those patients that have those little yellow spots that have drusen in the back of their eye, there's only one treatment that the doctor can prescribe that helps prevent that disease from progressing. And that's very high dose eye vitamins with zinc. And what VitaRisk does is VitaRisk tells the doctor for that particular patient which formulation of those various ingredients are the perfect formulation for that patient to prevent them from progressing to lose their vision. So again, 2 tests. Will the patient go blind in the next 2, 5, or 10 years? And what formulation of eye supplements and zinc are the right formulation for that particular patient?
Greg, one thing you might want to emphasize is that for some people with some genetic groups, if they take the conventional doses of vitamins, it actually accelerates the risk of going blind. It's doing them harm.
Right.
And for other folks, they derive a terrific benefit. And so in order to know whether you're in that group that's going to do well or that group that's going to do very poorly, the only way is really by understanding what your particular genetics are and allowing that to guide your choice of therapy.
So tell us about the presentation or the protocol based on your experience that you've developed for offices and for practitioners.
Yeah, it's, a protocol is very important. Once the test is done, there needs to be a follow-on disease management program that the doctor can adopt in this practice or her practice. And so we didn't develop the protocol. What we did when we look at the results of the test and the various levels of reporting, we took the test and the reporting schedule out to eye care professionals, to optometrists, to ophthalmologists, to retina specialists, and looked to them to guide the development of a protocol for the management of a patient. And what it basically comes down to is that when the eye care professional looks into the back of an eye of a patient and diagnoses a certain stage of the disease, by matching where the patient's disease is today with their genetic profile, the doctor starts to really understand how urgent or how relaxed he or she can be in the management of that patient. So the protocol might require that the doctor sees that patient once a year, might be every 6 months, it might be more or less frequent than that. And then again, which high-dose eye vitamin formulation with or without zinc is the appropriate formulation. And the last part of it is, as the disease progresses in some patients, when should the primary eye care professional refer that patient to a retina specialist? And that is one of the most important components of the protocol. Because what happens today in this disease is most patients don't know they've got the disease until after it's too late and they've lost their vision. With the ability of the primary eye care professional to know who's going to progress, to monitor them routinely, to treat them appropriately and refer them early, there's a much better opportunity to save that patient's vision.
I see you have a test kit with you here.
Yeah.
Tell us about that a little bit.
Yeah, so what we do, and the way that this is done, is we supply the eye care professional with a series of kits to take the test. And these would sit in the lane in the examination room or with the technicians in the office. And what's required, quite simply, is just a little cheek swab. So inside the package, there are 2 little sleeves like this that are sterile. Open it up, take out what we call the swab, and it's fairly simple. It's just a little nylon brush on the end of this stick, and rub this inside the patient's mouth about 20 times on one cheek, and then take the second swab for the other cheek. Put them back into the sleeve and drop them in the post. That will then take the kit or the test for that particular patient to our laboratory, and we'll generate the test result and send that back to the doctor. It's fairly simple to do.
Interesting. There are other products available on the marketplace, I understand. What's the difference between the products that you offer and what's available in the marketplace?
Well, there aren't many other products in the marketplace that offer similar testing, but there is one competitor.
Mm-hmm.
There's a competitor that's offering a test that has the ability to predict 2, 5, and 10-year risk of developing advanced AMD, but does not have the ability to predict what particular vitamin formulation is best for them. And so while it's nice to know what your particular risk is, what's really equally important is to know what you should be doing in order to ameliorate that risk. And we feel that these are 2 aspects of the same kind of question. That first of all, how severe is your risk? And the other is, what do you need to do about it? And it's only through having those things together that really allows a positive outcome. And that's why we think that VitaRisk and macular risk really are the only tests in the marketplace that have that ability to provide that patient benefit.
Wonderful. Talk about the personalization that you can provide as you're providing these tests and giving feedback to the practitioner. What personalization can he provide each of his patients?
Well, I'll have a go at answering that. You know, age-related macular degeneration is really a unique disease in terms of human medical science. That there are everyday reports that there are diseases that are associated with some genetic abnormality. You can't pick up the paper without reading about something. Genes are everything.
Mm-hmm.
But for the most part, the contribution of these genes to risk is minuscule. It's absolutely minuscule.
Mm-hmm.
The difference with age-related macular degeneration is that the contribution of disease, of the genes to the development of the disease, is about 80%, meaning that from birth you could predict with about an 80% accuracy who it is that's going to go on to develop the disease. So when we first became aware of this particular science, we recognized that there was a great opportunity for individuals to see what their genetic components are and to be able to then tailor-make a follow-up schedule, an imaging schedule, and also now a vitamin prescription to minimize the chance that they're going to develop late disease. We also know that if you detect the progression of age-related macular degeneration to the wet form, you only have a very short window of time that if you ignore the disease beyond that, even the most expensive injections that are now used to treat the disease are quite ineffective. But if they're provided earlier in the course of the disease, vision can be maintained and even restored. So we think that there's an imperative to both understanding on an individual level what your risk is, on an individual level to tailor making a follow-up, maintenance, imaging protocol, and also to provide on an individual basis a prescription for vitamins that are going to slow down or prevent the chance that you're going to get the disease. So in a previous era where we thought that one size fits all, that's no longer true in AMD. Each individual needs to be treated differently.
There's no shortage of vitamins that are available in the marketplace. Tell us about the importance of vitamins as a whole and some of the challenges that are probably pretty obvious to a number of practitioners about compliance with any regimens of vitamins.
I think that's a good topic, Grant, because we've all grown up with vitamins. I hearken back to, I think when I was about 5 years old, my mom got me my first Flintstone multivitamin, and so we all tend to believe that vitamins are good for you. They're a nice to do, and you should do it. It's part of nutrition. But what we're talking about here is a little different. What we're talking about here is the treatment of a disease, where the dosages of the vitamin formulations are about 10 times the dose that you would see in a regular multivitamin. So for the doctor that's providing that personalized care to the patient, it's not simply providing a multivitamin that the patient might be able to go to the drugstore somewhere and pick it up. These are specifically formulated for this disease, for the treatment of it, and when you get into dosages of zinc, for example, that are 8 to 10 times the normal dose you'd see in a multivitamin, you're talking a therapeutic dose. And zinc, for example, and I'll pick on that just for a moment. It's been a supplement that's been associated with helping to boost your immune system. And one of the things that we measure in macular risk and VitaRisk is the genetics related to your immune system. And if you have a great genetic profile around that immune system, zinc is one of the best things that you can take. It's fantastic. But if your genetics are not so good around your immune system, zinc can actually be potentially toxic and accelerate inflammation and accelerate macular degeneration and probably other diseases as well. So it's really important that we not just think of this as being a vitamin or a multivitamin approach, but more of a therapeutic approach that the eye care professional has the tools to be able to select and develop a protocol that's right for that particular patient, and it's quite different than just self-medicating with a multivitamin.
Lots of experience in the marketplace so far with your products. Tell us about retinal specialists. What are they saying about genetic testing in general?
Yeah, retina specialists are actually some of our strongest supporters. However, this is a disease that is managed both by the primary eye care professional and by the retina specialist. The retina specialists are the doctors that get the patient after the train has wrecked, after the patient's had a bleed in their eye or has got a problem and they need either a surgical intervention or an injection in their eye. And in other words, the patient's already progressed to advanced macular degeneration and lost vision. So our test is almost too late for the retina specialist. The patient's already progressed to the point where you don't need to know what their 2, 5, and 10-year risk is. They've actually already progressed. It's happened. Whereas the primary eye care professional, the optometrist, the general ophthalmologist, are the doctors that are going to catch patients with early macular degeneration for the most part. And they're the ones that need to know how to manage that patient so that they can follow the progression of the disease, treat it appropriately to try to prevent it, and refer that patient to the retina specialist if they do progress past the elementary dry macular degeneration form.
Always pressing for time
Yeah.
in today's day and age, especially in the office. How long does it take to do this test?
It actually takes hardly any time at all. The actual taking of the swab can be accomplished in just a couple of minutes. We have the logistics streamlined so that the individual offices need not worry about pickup of the samples, about paying postage or courier costs, and that the reports are actually sent back electronically, and the interpretation is actually provided for the doctors on the charts and on the reports. And we've really tried very hard to make it minimally disruptive in the office for the practitioners.
Gentlemen, I want to thank you so much for the interview for today. I appreciate it very much.
Thanks, Grant. Appreciate it.
And for our viewers, if they want more information, they can go on www.macularisk.com. Thank you very much.
Thank you.